Hello, my name is Dr. Melissa Stiles with the UW Department of Family Medicine, and I'm joined by Dr. Jeff Patterson, Professor of Family Medicine, and today we're going to be talking about erectile dysfunction. Thanks for joining me, Jeff.
It's a pleasure to be here.
Jeff, it's not uncommon for erectile dysfunction to be a by-the-way question. Someone comes in for knee pain, elbow pain, and then you finish up and they say, by the way, doc, can I get a prescription for that blue pill?
That's often true, yes.
How do you approach the problem in a typical office visit?
Well, obviously at that time is of the essence, and one of the important things may be to initiate the interview and ask for a follow-up visit. But unfortunately, most men are anxious to get the pill because they need it this weekend or sometime soon. So I often do a very brief history to think about the initial things that might be problems, and then might give them 2 or 3 pills with some admonitions about it to see how it goes.
What are the causes of ED that need to be considered?
Well, I think the most important things still are lifestyle, psychological issues, and relationship issues. We now know that percentage of erectile dysfunction certainly has to do with physical factors that may be vascular, hormonal, etc. But I think by far and away the psychological still outweighs those things.
What do you focus on in the physical exam, and are there any routine tests that you order?
Certainly. The physical exam, I think, is the second thing. The history, which we'll talk about in a minute, is probably the most important piece to this. Physical exam, I think, general physical, looking at vascular issues, and then making sure the testicles are normal size, not atrophied, that there's no evidence of Peyronie's disease, curvatures in the penis, etc. And thinking about the common things that might be appropriate on physical exam, vascular problems probably is number one. And if somebody has vascular disease in one area of their body, for example, because of diabetes or they have known heart disease, then there's a fair chance that they're going to have vascular disease in the microcirculation to the penis that can affect erectile dysfunction. I think the other things then in terms of laboratory work that I think about would be a comprehensive metabolic panel looking at liver functions, kidney functions in particular. Then thyroid testing, I routinely do a TSH, T3, T4. Both hyper and hypothyroidism can affect erectile dysfunction. Testosterone, and I usually get a first morning testosterone and a free testosterone along with that to look at that. If it's a borderline value, I'll probably repeat it and see what it looks like. And then lipids are another important factor in looking at those. And then especially if people have a loss of desire, then I think a prolactin level is very important because both low testosterone and high prolactin can give people a loss of desire in their sexual functioning.
What are the key components of the history? What do you focus on when someone comes in?
The history is, I think, probably the key issue here. And so I want to know when the erectile dysfunction started, how it happened, and what kinds of factors went into that. I want to know about relationship issues, and sometimes it's important to bring the partner into this, to do a separate interview or a combined interview with the partner as well. I've certainly seen cases where the partner is pressing to be sexual and the male having the erectile problems doesn't want to be sexual, and so that's a different issue in terms of desire. So those kinds of subtle relationship issues can be very important in this, and I think a fair amount of history in this area is a key to this. In addition to that, looking at the issue of spectatoring. And spectatoring is basically sitting on the side of the bed watching rather than participating in the sexual event. And the male penis is a very fragile organ, actually, and it doesn't take much for it not to function well. And what happens is when we get into a situation where we may get a partial erection or not get an erection, and then the next time we're in a similar situation, we begin to think, boy, is it going to get hard this time? And the minute you think that, even subtly, it doesn't. And so discussing that with the patient is important because oftentimes people can relate to that very well. They say, yeah, I am. I begin to think about this and begin to worry about it. And then you're sitting on the side of the bed, we call it spectatoring, watching the event rather than actually participating in it.
In building on that point, what are the positive and negative predictors of outcome? Some of them will.
Well, I think on the physical end, the difficult issues are other vascular disease, and probably diabetes and cigarette smoking are the biggest causes of vascular disease. I think obesity, lack of just physical stamina as we grow older, and then relationship issues that are not favorable are probably the biggest predictors of negative outcomes. Positive outcomes, if you've got a partner who's cooperative and not pressuring, and that's another issue. Sometimes the partner is pressuring to have you get an erection, and chances are you're not going to get one when there's that pressure. Partners who can work together on this and communicate, and communication is very important in this. And again, lifestyle issues, I think, are a positive outcome. If you're a non-smoker and do some exercise, modicum of exercise, then I think the outcome may be more favorable.
Well, let's go back to the blue pill. Can
Yes,
you briefly
very
discuss
good.
the medications?
Sure. So medications have changed things pretty dramatically in terms of the treatment of this, and they are the Viagra, which was the original one, Cialis and Levitra are the three that are out now. And the upside of these is that they can have a very positive effect on producing erections, which we can talk about. The downside is that often it's the case where the male just wants these pills and doesn't really want to do any other counseling or any other thinking about this. And then if you prescribe the pill and it doesn't work, then you're in deep trouble, because then there's a more deep-seated psychological factor here. Even this medicine, this powerful medicine hasn't worked for me, and so I really am in trouble now. And so I think there's probably a fair number of men who, when this happens to them, they don't even come back to the doctor, which is why I think having, again, that history and follow-up and discussing this issue with patients, that, if this doesn't work, we really want to deal with that, and it's possible that it might not. Having said that, I think if it seems appropriate, you've ruled out physical things, there aren't terrible relationship issues, and you've talked a bit about the process of taking the medications, then I think prescribing them can be very useful, especially if you think there are psychological factors that may be involved in this. New relationship, something's happened in your relationship, other stress factors, may get people just over that psychological hump enough to allow them to function normally after that.
And what other treatments are available?
Sure. The other treatments, of course, therapy, and I think therapy shouldn't be discounted in this. And that can be all the way from just individual therapy, talking with the male about this, talking with both partners, doing things like banning intercourse. If you get an erection, that's fine. You enjoy it. You may do some mutual stimulation, some touching and caressing and whatnot, but banning intercourse can take the pressure off of that. So again, therapy, and all the way to intensive therapy with a trained sexual therapist, is certainly one useful avenue. Other things are pumps and vacuum pumps, and there are a variety of those, some that are very reasonably priced, that you put on the penis, pump it up, and it pulls blood into the penis, and then you slide a cock ring off onto the base of the penis that holds the blood in the penis. That can be very effective in giving a good erection. The downside is it's kind of a floppy erection. It has nothing holding it at the base, and so that can be a negative thing for people. Of course, if there are physical problems like low testosterone, then testosterone treatment is appropriate with whatever form, injectable or creams or whatever. The issue of using injections in the penis can be done, but it's just not done much anymore. And most men don't, even if they are prescribed, they don't last long doing it. So I haven't used those for quite some time. The implants, I think, is kind of a last resort, because once you put an implant in, it destroys the corpus cavernosum, and you can never have a normal, natural erection again. But for somebody who has well-proven vascular disease or a physical cause for the erection things, the implant can be quite a positive thing. But I think most urologists, they went through a phase of doing a lot of these, and we saw some rather negative side effects as well, but I think they're pretty rarely done now.
In summary, Jeff, what are the key teaching points you want to convey regarding erectile dysfunction?
Well, I think the important thing is really doing a very careful history and conveying to the patient that you're concerned about the spectating issues, psychological factors, which are, even if you have a physical problem, those factors are present. And so it's impossible to tease out and know, is this purely physical or purely psychological? And it's often a combination of those things. So I think, again, the careful history and careful explanation to the patient of what may be going on is probably the most important factor here, developing that relationship and then doing follow-up, not just giving the pill and leaving the patient to their own thing that they're going to do. Because, again, if there's failure, they're really lost at that point. Yeah.
And where can people go for additional resources?
Well, I think there are two great resources. One is AASECT, which is the AASECT, the American Association of Sex Educators, Counselors, and Therapists. And they have a great website and lists of well-trained sexual therapists around the country and lots of materials on their site as well. The second is a book that I highly recommend. It's called The New Male Sexuality, and it's in paperback, written by Bernie Zilbergeld, kind of a tough last name there, Zilbergeld. And it really is a superb book that talks not just about erectile problems, but premature ejaculation, desire problems, etc. And so I often recommend this to men and might recommend specific sections, and many of them end up reading much more than that. Dr. Zilbergeld was a well-known sexual therapist whose interest was in male sexual problems.
Oh, wonderful. Thank you very much.
Thank you.